And remember, please put your questions inside the Hoover chat. So any questions that I don't get to today, I would definitely, during this presentation, I would definitely go into the Hoover app and answer your questions. All right. Hi, everyone. My name is Dominique Goodson. Today, I will be speaking on advocacy for standard ER care. As we all know, as either warriors, caregivers, or just medical professionals, that the standard ER care for sickle cell patients are not that great. And actually, that's not true. When we are in pediatrics, when we're kids, when we're like the little goobers, we are treated like little princes and princesses. Like our word is everything. We're never questioned whether we're in pain, any of that. So when we're in pediatric, it's an amazing experience. We feel that understanding. We feel that we are believed. But once you hit that 18, you turn 18 and you get kicked out and you get to adult section of ER care, it is a complete different thing. I learned that when I was in college. I went 5 years without having a crisis attack, not one that I had to take care of at home or one that I had to go to the ER until college. When, as you know, as you get older, more stress and stuff comes on. And I remember after graduating from college, the hospital I was going to at the time was a very good hospital. I never had more than, I want to say, a 30-minute wait time of getting in the back, seeing a doctor, getting my pain medication, or any of that, until I actually moved back home to the hospital I was originally going to. And I remember the first time I had a crisis attack and I went to the ER. I waited in the ER, the triage section of the ER, for 8 hours, counted 8 hours. And I know there has been a lot of people that experience the same thing. It's a 6 to 8 hour waiting time. And I remember going to my doctor afterwards because they thought I ended up having acute chest syndrome because my oxygen sats had just dropped so low. And then after I almost passed out, they want to do everything. I'm like, why you guys want to do something now when I've been sitting out in the ER for 8 hours and saying, look, this is happening, I'm not doing well. Can you please see how long it's going to take? And it's the same question over and over. So after that very horrible and traumatic experience in the ER, I went to my doctor, my hematologist, and I told her, I said, hey, I'm realizing the wait time in the ER is absolutely ridiculous. It's crazy. We should not have to wait 8 hours in the ER to get seen. And she was like, yeah, that's true, because you guys are supposed to be triaged at a certain level. You're supposed to be seen first. But there's X, Y, and Z happen. I was like, no, I get that. People who are having heart attacks and who got shot or something, I'm not saying see me before them. But there's no reason why some dude comes in with a stomach ache and gets seen first. Like his stomach was hurting. There was nothing ruptured or anything. So I get that. But when I've been waiting in pain for 8 hours in an emergency room, do you know how much damage that could have done to my body or what it could have really been? So she was like, that's right. I was like, we need to do something. Something needs to be changed. And so the first thing I thought about was like, you know what? Let's do a support group. I was like, we need that because as warriors, we need other warriors to talk to, find out, hey, how do you get seen faster in the emergency room? And I'm not gonna lie, that first support group meeting we had, we exchanged all types of secrets. That's when I told one person what I learned about going to the emergency room. When you get to the front door, just collapse. Everybody come running there. You'll get seen faster. And they're going to be upset when they just find out that you just lied and you just like, it wasn't as bad, but you get seen faster. Just get to that door and just collapse. And like all of us, we had all these main stories. And by the time of the end of the meeting, we were discussing how bad the ER was. And I remember hearing one person say, well, shouldn't we have the head of the ER here or someone that's running the ER, nurses or doctors in the ER to hear our understanding? And our sickle cell nurse, Marcus. And this is not something you can do alone. You are going to need help from the hospital. You are going to need help from the ER. You're going to need the head of the ER that's going to actually put in that time and make sure that all of his doctors, residents, and nurses and stuff are following directions. You're going to need the help from the head of the ER, from the head of the hematology department that you go to. It's going to be steps that you need. And the most important thing, you're going to need the voices of the patients and the caregivers. That's the most important thing. Because if that guy didn't say, hey, wouldn't it make more sense for us to have the head of the ER doctors and maybe some nurses here to explain to them what is going on, then that this might change a little. So our next meeting the following month, we actually invited the head of the ER. We had an amazing meeting. He took notes. He was very listening, and a lot of us explained, sometimes we don't need to stay in the ER. Sometimes we don't need to be admitted. Our pain medicine at home is just not working, and we need something stronger. We may need only 1 or 2 doses, and then we're able to go home. From that meeting came the Sickle Cell Advisory Board. And it's where you have the head of the hospital, the head of the hematology, the Sickle Cell nurse coordinator. You also have CBOs from around the area, and you have advocates and caregiver advocates that are speaking and going to these meetings quarterly to say, hey, this is what the patients needs from the hospital. This is what we need to focus on. This is what we need to do. And our first thing was to tackle was the treatment in the ER. We are treated horribly as adults. I'm not saying pediatric, as adults, because y'all know pediatrics. We had Sega Genesis when I was in pediatrics. We had everything. Now sister can't even get a glass of water without talking about some, oh, you overreacting. So this is strictly for adults. So from that, the advisory board for sickle cell at my hospital came great changes. Having those quarterly meetings, and this is not something that's going to take time. We were actually asked, there were working meetings that we had with the head of the ER, the charge nurses of the ER, the hematologist, the sickle cell nurse coordinator, CBOs, and then other prominent advocates and caregivers in the community came to those meetings and were asked, like, hey, how do we go about making these changes? What it is that we need? And then 2 years later, yes, because it does take time, because the doctors and stuff have to do the research and make sure this is everything is, we have the 30-30-30 rule. And so in my hospital, what it is when you first get into the triage, after you're a triage and you get to the back, within 30 minutes, you're seen by a doctor. Your orders are placed in and put in, when then and you get your first dose of pain medicine. Within the next 30 minutes, you are reevaluated again. If you need more pain medicine, you get more medication. And when the next 30 minutes after that, that is the last evaluation. If you're feeling better, you could go home. If you're not, you're admitted and you're given your 3rd dose until your hospitalist comes and put in all your orders and charts. Now, it took us a while, I'm not gonna lie, because practice makes perfect. It took us a while where we were able to get it down packed, and triage is still an issue when it comes to it, because you have some triage nurses that don't want to actually follow the rules and everything. But since that's what I want to say, like 8 years ago, when we implemented that, the wait time in the ER for us is so much lesser. We literally went from 8 to 10 hours to maybe 2 hours, if that, the max. And that's if it's on a busy night, because you guys know how it is Monday through Wednesday. It gets like really busy, and so you might have to wait. But it's still that 30-30-30 rule that they follow. And we just didn't implement that. We also implemented sensitivity training. I think a lot of doctors and nurses have a preconceived notions about sickle cell. Oh, there's nothing we could do. It's only pain medicine. A lot of them are drug seeking. We don't hear this when we're kids. We only hear this when we're adults. So we implemented sensitivity training once a year for the new ER residents and doctors that are coming in. And they get to speak to a sickle cell patient that is not in a hospital, that is not feeling at their worst. Let you know, we got our hair done. We sitting up there looking good. It's about to be some bacon barbecue food. And that we can eat and we talk and explain what it's like to have our condition. And that all we ask is for them to treat us as we want to be treated. So I know, I see time.
Yeah, I just wanted to tell you that Naomi from the UK said that the patient experience is just the same.
The ER, the
Yeah,
experience isn't that much different here. Oh,
yes.
I am so sorry to hear that. You know what I'm realizing, and spoken to a lot of sickle cell warriors across the country, across the world. They have a lot of the same experiences that we do have in the US. And it sucks. And I hate this stereotype and the stigma that is placed upon sickle cell patients. I went to FSEDR and I had to check a doctor on an airplane, a recently graduated medical school doctor, just graduated medical school, and has started his residency in Florida. He had the audacity to say, "Oh, you can tell when a sickle cell patient a sickle cell patient because all they do is drug seek." Oh, so you knew I was one then. Like, it's what they're taught in medical school that we have to break. Take those opportunities. Yes, I know when you're in pain, you don't want to take that opportunity to sit up there and teach a doctor that should know better. But they don't know what they don't know. They only are hear through the grapevine that this is what sickle cell patients are until they actually get speak with another sickle cell patient or know another sickle cell patient or actually have those sensitivity trainings that we have at my hospital. I get told all the time by the doctors, it's like, you know what, your speech really helped me. It changed how I'm going to treat sickle cell patients. I was wrong. I did come in with a preconceived notions that all they wanted to do was seek for pain medicine. He's like, and I do apologize for that. And I'm going to do better. And I'm going to teach other doctors and tell other doctors to do better as well. Those things right there has made a world of difference at my hospital. We
Excuse
hear
me,
less
Dominique,
complaints
Kiana's
about,
raising her hand.
oh, I say I am. We see less complaints about ER doctors and how they're talking about, oh, well, this amount of pain medicine will kill me. Well, I don't care what it would do to you, but it's about to help me not be in pain. So this is not an easy process. And it took about 3 years to do it. But we were determined to change things. I know I wasn't letting it go to change things at my hospital. I couldn't go another 3 years with waiting 8 to 10 hours in the ER in pain like that. So I see Kiana has her hand raised. Kiana?
Yes, I have two questions to ask. One, how do I implement the 30-30-30 rule? Is it do I need to speak?
You're muted. You muted yourself, Kiana. Can you repeat your question? Because you muted halfway through.
I think it's a signal.
I'm sorry, is that better?
Yes.
Okay. How do I implement the 30-30-30 rule into the hospitals here locally? Do I go to the triage person over triage, or how is it supposed to get implemented so that everyone can follow it?
So the way we got it implemented was we went to the head of the ER, and then we went to the head of the hematology department. And unfortunately, not everyone has, and I'm blessed in so many ways for my hospital, not everyone has that head of hematology that is dedicated and then put in work for sickle cell. Actually, the head of my hematology department is actually writing down what was the steps and how they went about with coming up with the 30-30. But you first have to go to those people because those are the ones that can implement it, that can actually do it. You need the head of the hematology because she's the research that you need. She's the one that's going to tell the head of the ER doctor, like, hey, this is what the rules are. You can look it up at the CDC. There are a whole procedure set up. It's just that some hospitals refuse to follow it. And if you want that, you have to first start with your head of the hematology and the head of the ER, because we could say that we want it this way. And I know I brought plenty of documentations showing that this is the care that the sickle cell patients should get, whether it's printed out or they go to the website or the medical journal themselves. When it comes for a patient, it seems like it's less believable. But when it comes from a fellow doctor, it's more believable. So having that head of the hematology and the head of the ER work together to come and sit down and do that and then taking the input of the patients and caregivers, that is the first step you have to do. And unfortunately, I've heard some hematologists like, well, no, I'm not really focused that much on that. I care more for oncology than hematology, or I don't have as many sickle cell patients. Because at my hospital, we have over 3,000. So we have a lot of sickle cell patients at my hospital. And it's not like that for some. And that is a lot of work that is going to have to be done. But if you're consistent and you have other advocates and stuff helping, pushing it through, you can do it.
Thank you so much. My second question was, when should the sensitivity training be implemented? Is it a certain time of the year I know following through the 30-30-30 rule, but what part of the year should I really push the sensitivity training as well?
We normally do the sensitivity training. We make it a barbecue, so we do it in the summertime because we do invite patients and caregivers to it. We want patients that are healthy so that so the doctors can see what it's like for a sickle cell patient when they're healthy, when they're fine, and when they're not sick. So typically we try to do it, I believe it depends on the hospital, but a lot of new residents come in like around May, if I'm not mistaken. So we tend to do it July or August and do it then because it's the new residents that are working in the ER. They don't know the sickle cell faces like the other ones did. So it's giving them the opportunity to see the faces and also get information, real information that they didn't get while they were in medical school during that time also. So we typically do it during the summertime, like July or August. It looks like I think we may have.
Thank you. We kind of ran out of time for this session. Yeah. If you can put your questions in the Q&A, then we will definitely read them. And also it's good to network and please, if you have a discussion, we can join that discussion. If you have more questions about this particular ER advocacy. So we know this is an important topic, and joining those advisory boards are definitely key also. As you know, Dominique mentioned, they formed an advisory board. So a lot of these hospitals, local hospitals already have one. You just have to come involved to join it and then be a part of that voicing community that's making that effort to make changes.
Yeah, thank you. And for the questions that I didn't get to answer, I will answer them inside of the Hoover chat. So please feel free to ask any of the questions and I will go and answer all the questions I can in the Hoover chat. Thank you guys. I hope this was very helpful.
Yeah, everyone is responding that it was helpful and they were just concurring with your experience. Of course, they've also had some mortifying moments at the ER, and there's just a consensus all around the board. So thank you so much, Dominique.
Thank you guys.